We start our session today on menopause and hormonal replacement therapy, second part of the talk, and we'll deal mainly with the management of the menopause. The management of the menopause in general includes lifestyle changes, hormonal replacement therapy, natural hormones designed to be ingested or applied to the skin, pharmacological alternatives, non-hormonal prescriptions treatment, and complementary drug-free therapies driven by practitioner. So the lifestyle, hormone replacement therapy, natural hormones designed to be ingested or applied to the skin, pharmacological alternatives, non-hormonal prescription treatment, and complementary drug-free. So we'll go on them one by one. We see the lifestyle, how that affects the menopausal symptoms for the lady. Women who are more active tend to suffer less from the symptoms of the menopause. So activity here is an advantage. The best activity is aerobic, sustained, regular exercise. So here it has to be regular and it has to be sustained. Avoidance of reduction of intake of alcohol and caffeine can reduce the severity and frequency of the vasomotor symptoms, as well as stopping smoking. So avoid or reduce or stop alcohol intake, caffeine, and stop smoking. The body mass index, or at least the weight of the lady, should be normalized, whatever expected weight regarding her size or her height. So the hormone replacement therapy, we dealt with the lifestyle. The hormone replacement therapy is the first line of treatment, and it remains the most effective form of treatment. If we give the lowest effective dose for the shortest time, that will be the ideal situation. And the hormone replacement therapy consists of giving hormones. The hormones are either estrogen, progesterone, combination of both estrogen and progesterone, and testosterone. Testosterone could be given separately, or it could be part of a combination that contains both estrogen and progesterone. Estrogen, if given alone, it stimulates the endometrium, increasing the risk of endometrial hyperplasia and cancer. So when giving HRT in the menopause, we have to look for that particular serious side effects of estrogen. As we will see, a woman whose uterus is intact, we need to give her both estrogen and progesterone. If the uterus has been removed, she had a hysterectomy, then she could have estrogen alone. This is what I just have said. Women without a uterus can be given estrogen therapy alone. Women with a uterus should receive progesterone therapy in addition to their estrogen therapy. The reason is that estrogen on its own stimulates the endometrium, causing endometrial hyperplasia and possible cancer of the endometrium. So having said that about the drugs being used, they could be given in different forms of treatment, either oral medications or topical medications, including gels, patches, and sprays, or they could be given in form of vaginal rings and injections. Women with an intact uterus who desire contraception, the levonorgestrel releasing intrauterine system may be an appropriate method to use. that is the Mirena, which contains progestogens, and it could replace the progestogen in the oral formation. So in this lady, you can give her estrogen alone, while progesterone is being provided by the levonorgestrel releasing intrauterine system. This is the way it could be given: patches, either to the thigh, to the shoulder, sprays, injections, creams. So these are the forms in which the HRT could be given. It's easy to use. Obviously, oral is part of them. In the menopause, we have mentioned earlier on, there is a genitourinary syndrome or symptoms coming from the dry vagina, loss of labia thickness, going into the shortening of the vagina, going into dyspareunia, into urinary tract infection. So all these, we call them the genitourinary syndrome. And the treatment for this form of symptoms could be either moisturizers and lubricants, such as repellents, Astroglide, KY gel, coconut oil. These relieve the symptoms related to vaginal dryness and dyspareunia. Anything lubricant. Low estrogen therapy improves the vaginal atrophy, dysuria, and urinary tract infection. So different forms of local estrogen therapy are available. Local estrogen therapy improve the vaginal wall, vaginal dryness, and dyspareunia. Low-dose estrogen creams available. Vaginal tablets, which contain estradiol 25 gram, are given vaginally as one per day for 14 days, followed by twice per week. So we can give them vaginal tablets and estradiol vaginal ring. It's a silicone ring placed in the vagina for 3 months. So the genitourinary symptoms could be given by applying local estrogen therapy in a form of creams, tablets, or vaginal ring. Having said that, what are the benefits of hormonal replacement therapy? The HRT use results in excellent control of menopausal symptoms, the one we have mentioned in our first part of the session, and that is reduction of the vasomotor symptoms, improvement in the mood and sleep dysfunction, prevention and treatment of the genitourinary symptoms of the menopause, improvement in skin and muscle tone, and prevention of bone loss. So the benefits: relieving the symptoms, preventing some of the symptoms to occur, especially the genitourinary symptoms, improvement in the skin in general and the muscle tone, and prevention of bone loss, as well as the prevention of or reduction of the cardiovascular disease that may occur. The earlier women given the treatment, the better the results are. If the treatment is given before the age of 60 years or within 10 years of the final menstrual period, so we'll get good results. The better the results are. Increased rates of stroke, deep vein thrombosis, cardiovascular disease, and dementia are seen in those who start later. Still stressing the point, when you start HRT, please start on it as early as possible if the patient needs it. And as we said, some of the patients may endure the symptoms and they may not come to you. HRT should not be used for the prevention of other chronic diseases such as cardiovascular disease, coronary heart disease, or dementia. It shouldn't be the indication for prevention of those. Contraindication to HRT, quite a list. If there is suspected pregnancy, chronic liver impairment, uncontrolled hypertension, non-estrogen dependent neoplasms such as those of the breast, the ovary, and endometrium, active thromboembolic disease, known thrombophilia, e.g. factor V Leiden, autosclerosis, undiagnosed uterine bleeding, large uterine fibroids, past history of benign breast disease, unconfirmed personal history or a strong family history of venous thromboembolism, if the lady has migraine with aura. So quite a big list of the contraindications of HRT. One must be very careful when trying to give the HRT to see that there is no contraindications. These contraindications could be absolute, some of them could be relative. The next group of treatment is the natural hormones. These are designed to be ingested or applied to the skin. They are naturally occurring. Dihydroepiandrosterone, steroid, progestogens as an alternative to combine HRT in women with intractable vasomotor symptoms who have contraindications to estrogen. So the natural hormones to be used is one is the steroids, two group, androgens, dihydroepiandrosterone, and progestogens. Progestogen should be used in women who have an increased risk of breast cancer. Progesterone, transdermal creams, progesterone creams derived from the wild yam have been advocated for the treatment of menopausal symptoms and skeletal protection. So we go in for steroids, as I have said, progestogens, either naturally occurring in the yam or chemically in form of treatment to women for HRT who have an absolute contraindication to estrogen, so we can use progestogens alone, or we can use steroids, dihydroepiandrosterone. Then the third group is the pharmacological alternatives. Here, alpha-2 agonists, common one being used is clonidine, centrally active alpha-2 agonist, one of the popular alternatives for the treatment of vasomotor symptoms. Second group is the beta blockers, treating also the vasomotor symptoms, but the small trials have been disappointing, unfortunately. So it's being used, still under trial, could be very effective. The third group we use here is the selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. The example being given is fluoxetine and paroxetine. Another inhibitor we use is the selective noradrenaline reuptake inhibitors, venlafaxine. So selective serotonin reuptake inhibitors and selective noradrenaline reuptake inhibitors. All these could be used as alternatives. Gabapentin, research work with the anti-epileptic drug gabapentin has shown efficacy for hot flushes reduction compared to a placebo. So gabapentin could be used. Non-hormonal prescription. These include vitamins and minerals, Vitamins such as vitamin E, vitamin C, minerals such as selenium are present in various supplements being given to menopausal women. Homeopathy, improvement of symptoms of estrogen withdrawal in women with breast cancer, for example. Hot flushes such as fatigue, mood disturbance also appear to be helped by homeopathy. Acupuncture, a recent small randomized study in postmenopausal women showed a significant reduction in hot flushes frequency using shallow acupuncture, electroacupuncture. Reflexology, reflexology, reflexology aims to relieve stress or treat health conditions through the application of pressure to a specific point in areas of the feet. Something like physiotherapy, whereby doing pressure on certain points recognized by the expert, then it has been shown that this improves the symptoms of the menopause. Another group is the complementary therapies. These are natural preparations designed to be ingested, and quite a list varying from natural plants in different parts of the world. We start with phytoestrogens, plant substances that have effects similar to those of estrogen. E.g., isoflavones are found in soybeans, chickpeas, red clover, and probably other legumes. So these are legumes which are being used. It has been shown that they have some beneficial effect on the symptoms of the menopause. The second is the soybeans, reduces hot flushes, but long-term treatment has raised concern with regard to a low risk of endometrial hyperplasia. So another natural therapy being used. The third group or third plant being used, red clover has a high content of the isoflavones, poiocyanine A, or formolnitine, while soy contains predominantly genistein, diazidine, and glycine. So you need to know that red clover could be used as supportive complementary therapy with or without HRT. Black cohosh, made from the roots of the herbaceous perennial plant native to North America, is a plant which is present all through the year, perennial, and from it, the roots, we got this black cohosh, widely used to alleviate menopausal symptoms. Evening primrose oil, rich in gamma linoleic acid. The sixth group of the complementary therapies, dong quai, also a plant which is present all over the year, and it is native to southwest China, commonly used in traditional Chinese medicine. Ginkgo biloba, it is a tree native to East Asia. The extract from the leaves is promoted as a dietary supplement. Some studies have shown a benefit for relief of anxiety and depression. So there's another plant being used, present in Southwest Asia or in East Asia. The last group of these supplementary or complementary therapies, St. John wort, effective in mild to moderate depression both in peri and premenopausal women due it is SSRI type effect, selective serotonin reuptake inhibitor effect. So we continue with the management of the menopause. We have talked about HRT, before it lifestyle, complementary drugs to be used, prescribed, natural, occurring from different plants worldwide. And we talk about testosterone. Is there a place for it in the management of the menopause? Of course, the answer is yes, because testosterone is being produced in women from the ovaries, peripheral adipose tissue, and the adrenal gland in women. So the ovary produces quite a good percentage of testosterone in the women's. If there is no ovarian function, there is a reduction of testosterone being produced. That could lead to different symptoms related to testosterone low concentration in menopausal women. These include lack of energy, lack of sexual libido, weight gain, slow metabolism, lean muscle loss, decreased strength, weakened bones. So a lot of the symptoms of the menopause have an element of testosterone deficiency in them, besides the estrogen deficiency. Joint pains and stiffness. So all these symptoms are present in the menopause, probably in part related to testosterone deficiency or reduction or production of testosterone. Thus, premenopausal women produce both testosterone and estrogen physiologically, just what we have mentioned. The decline in testosterone levels appear to be age-related, at least partly due to loss of ovarian function. So reduced or declined production of testosterone has an element of ovarian function reduction. Mainly, it plays a role in women's libido, sex drive or desire for sex after the menopause, bone and muscle health, mood, and energy. These are, besides the long list or part of the long list we have mentioned, these are the main things affecting the libido, affecting the bone and muscles, affecting the mood and energy in different forms. Dyspareunia is the most common complaint. Symptoms of vulvovaginal atrophy are also adequately treated if testosterone is being considered for the treatment. And we give testosterone supplementation. It should only be considered in women who complain of low sexual desire after psychosocial approach has excluded other causes. So we exclude the other causes, then a situation here arises whereby we have to give testosterone supplementation in the form of HRT therapy. NICE, National Institute of Clinical Excellence, the guidelines in the menopause commend that a trial of conventional HRT is given before testosterone supplementation is considered. So all the time, start with conventional HRT, symptoms removed, that's it. Symptoms are still there, and still the lady is complaining of them, then we go to testosterone supplementation. In testosterone-containing hormone therapy, the incidence of adverse androgenic effects such as acne and excess hair growth is higher. So you are giving androgens, you expect to get some side effects of the androgens, mainly acne and excess hair. So the lady may come and complain of having excess hair or the nature of the hair has become so coarse, like the male type. How we give testosterone. Some countries they give oral dihydroepiandrosterone, commonly used more than testosterone. Testosterone could be given in implants, but unlicensed in UK, probably the few time it would be licensed. When another option is to use testosterone gel. Orally, we have tibolone, weekly androgenic, progestogenic, and estrogenic, used by oral route for women with low sexual desire. Drugs commonly used now, combination of androgens, estrogens, and progestogens, and it's used mainly when there is a low sexual desire or loss of libido when the lady come complaining of it. It's being given orally. So implants could be used, gel could be used, oral route could be used. When treating low sexual desire or low sexual arousal, it's also important that the urogenital tissues are adequately estrogenized in women with vulvovaginal atrophy, genitourinary symptom syndrome. As we have said, those lead to vaginal dryness, atrophy of the vaginal wall, probably dyspareunia, and thus, if the main reason for giving testosterone to treat loss of libido or sexual arousal, then we have to treat the genitourinary symptoms prior to that, and then we can give the testosterone. And we have mentioned early on how we can treat the genitourinary symptoms. This should be the end of our second part of the talk about the menopause and HRT replacement therapy. Without any questions or comments?